Hey, thanks so much for joining us today for GM Insights. It is expert clinical insights in dementia care for your patients, brought to you by Georgia Memory Net. So happy that you could join us today. We have a distinguished and visiting speaker today joining us remotely. It's Dr. Linda Hill. She has an MD and MPH. She is the program director for the University of California, San Diego State University Preventive Medicine Residency Program. She's the director of TREADS, and that's a great acronym, Training, Research, and Education for Driving Safety. She's a senior staff physician and practices clinically with the San Diego Family Care, which is a 330 community health center. We're really glad to have you with us. Her work has been supported in the past by the California Office of Traffic Safety, the AAA Foundation for Older Driver Safety, Robert Wood Johnson Foundation, HRSA, and NIH. So we are so glad to have you here today. And I'm going to let you go ahead and start with your first slide, Dr. Hill.
Oh, thank you so much for having me as well. And you can both see my slides and hear me, correct?
We can see your slides and we can hear you as well. So thanks so much. You're good to go.
Okay, thanks. Well, in this brief period of time, there's a lot to cover. And so I would just suggest that if you have a question as we go along, that you just unmute and stop me because I think that will be the most efficient way. I've been working in the area of older driver safety for about 20 years, and we have a training, research, and education for driving safety. That's not just about older drivers. We also address pedestrian safety and bike safety, as well as impaired driving. And then an important area of our work is distracted driving. We don't just work with late drivers. We're also addressing commercial drivers. So we do a lot of work with truck drivers, looking at how to keep them from driving impaired and try to keep them from driving distracted. And most recently, we're looking at train drivers as well. So it's the same issues, just different mode of transportation. And when we think about driving safety, we think this isn't just one group's problem. A lot of physicians actually ask me, why is driving safety my problem? And certainly we don't want to wait for people to come to the attention of law enforcement, especially our older drivers. Equally, Department of Motor Vehicles, well, they do some screening. And in Georgia, I understand that your older adults need to present themselves in person every 5 years and get a vision test, but there's no specific written test. So nobody's really screening for the more worrisome age-related driving disorders. And then the community, of course, we do rely on the older driver themselves. A lot of people know how to self-regulate, as well as family and friends. One of the things that we do as well is train law enforcement to identify an impaired older driver. And we had focus groups with law enforcement and asked them, how do you know if somebody has dementia versus, or let's just say, some challenges that day, perhaps disorientation. We don't want law enforcement diagnosing dementia. Or versus, say, impairment from prescription or street drugs or alcohol. And they told us that it's very difficult, that they don't really have a model. We developed, working with the Alzheimer's group at UCSD, an orientation screen, really orientation to person, place, and time, that we trained law enforcement on how to use this and how to ask it at the roadside. And then our Alzheimer's Center tested this with both normal controls and individuals who had been diagnosed with some type of dementia. And we were able to show that it differentiates very well people from in those two categories. We also had the opportunity to bring this screen to a training that law enforcement was doing on how to identify somebody who's intoxicated. And we asked them to let us in so that we could test this tool with people who are intoxicated. It turns out if you're a volunteer getting intoxicated to help train law enforcement, at least that group, you do not become disoriented to person, place, and time, even when your blood alcohol level is climbing. So we were pretty happy that this tool differentiates very well. Law enforcement said to us, we're not willing to use anything that involves an iPad or a pencil because we don't want them to be used as a weapon against us, but we're willing to ask questions. And so now we have about 8 years of data on this, and law enforcement seems to be very comfortable with doing this test. We've been able to give them sort of ticket pocket-sized, the same size as a ticket, so that they can keep it with them in the carrier that they use for that purpose. And we also made an app for their phone, which we've distributed as freeware, so they can just pull that up on their phone and ask people questions. And in fact, the province of Quebec has written this into law that this tool be used on the roadside. We also work on educating older drivers, and we have a program called Drive Safe, Drive Longer. One of the nice things that we've had in California, and I'm sure that this would be an option for you as well, is our highway patrol is very community minded, and they're really interested in going out with really scientifically based curriculum that we vetted for them. So what TREDS has done, not just with the older driver topic, but with all of our other work, is we've used the public information officers of our highway patrol to be our change agents. California has 39 million people. Sorry. It would be very difficult for us to be able to do that kind of distribution. So sorry.
Dr. Hill, I'll give you a little bit of a coughing break here. So I remember in earlier conversations that we had, found that roadside law enforcement was very deferential to seniors and was very likely to reorient them to which way they should drive and then head off, even though they were dramatically cognitively impaired. So I think that this is not only a great awareness, but also a tool that they can use in these roadside stops to actually help older drivers who are disoriented and lost and the like.
That's true. And they've been very grateful to have a model that they could use rather than just trying to wing it. This is the kind of thing that we cover with the older drivers. Our goal is to keep them driving as long as possible. And as I said, most older drivers, they do a good job at self-assessment if you give them the tools. So that has been very well received. We also train a lot of health professionals such as yourselves. And we've been doing that for 15 years. And what we've found in talking to the doctors is that they've also sometimes been lacking a model within the very busy clinic that trying to fit in a way to systematically look at older driver safety issues. So we've been doing a lot of conferences and grand rounds. Our talks are usually about an hour. We've also posted this at our TREDS website. The other thing that we did for our TREDS website is we posted one of my colleagues, Dr. Moran, actually implementing the tools with a mock patient. So we try to talk to the docs about the fact that injuries are underappreciated in the office setting because I've been in the same practice for 40 years. I know I have so many competing priorities and tasks to complete. All of the U.S. Preventive Services Task Force requirements and HEDIS and charting and the COVID. So trying to get injury and driving safety on people's radar is kind of where I have to start. Also, the fact that most people outlive their driving. It's estimated that men outlive their driving abilities by 6 years and women by 10 years, which means that if we do our job right, our patients are needing to make that transition, make that retirement, and we want to help them make it before they're forced to make it by their family or law enforcement, they have the capability of doing that. I think one of the reasons that we don't have a specific age cutoff is because, as you know from your practice, you've got your very old 65-year-olds and your very young 90-year-olds. My dad's 95. He still works. He's writing a book. You know, he walks around the lake 3 times a week. He's better than a lot of my 65-year-old patients. So there's, biological and functional age. Nonetheless, we know in generalities that our older drivers are making kind of some common mistakes, mistakes related to having reduced reflexes, having some vision impairment, maybe having some trouble making decisions. And left turns are one of those big problems, and mistaking the the accelerator for a brake is another common one. So this may or may not play. It looks like it's not. So this was just a video of a 90-year-old just binging around a parking lot and hitting multiple cars. So vision, cognitive impairment, decreased strength, and all of the medical conditions that we accumulate with aging are some of the reasons that driving abilities decrease. And then the other issue, of course, is that we know that our older drivers and their passengers are more likely to be injured if they are in a crash. They're 4 times more likely to die than a 20-year-old from a crash of the same intensity. There are other conditions as well besides vision, cognitive impairment, and frailty that can interfere with driving, of course. Arrhythmias and Parkinson's, musculoskeletal problems, all that increase with aging. And then there's all of the medications that can have side effects that interfere. We've created some pocket guides. Again, I know how busy clinicians are. It's very difficult to take a break and look this stuff up. So we created some pocket guides, which are, pretty easy to glance at, to try to find the least offending drugs within a category. So if you have to choose, a sleep aid, which one is the least offending, this kind of thing. And I don't want to give this talk without mentioning alcohol. Alcohol is sadly still a cause of approximately 20 to 30% of fatal crashes in the United States. Just depends on the year. Unfortunately, fatal crashes are going up. We're at about 40,000 now. We were going in the other direction until COVID. I don't know if you realize how COVID's had this really paradoxical effect on driving safety. And it seems that what happened when our roads cleared is that people started driving more erratically and speeding. And then that's continued. There's been a kind of poor citizenship in a number of areas with crime, and the roads are one of those areas. I think it's worth mentioning cannabis as well, because the older 50, even older 60 group are using cannabis with the legalization at rates that they had not used when cannabis was not legal. And the cannabis of today is not the cannabis of their college days. The potency is vastly higher, as you're aware. And well, the literature on the effect of cannabis on driving is still a little murky. It's clear that if you're impaired, by whatever it is you're taking, that impairment reduces your ability to drive. And in our older patients, where they're already having other challenges, having any alcohol on board or any cannabis on board is a really bad idea when you're looking at driving. And in fact, we know that these risk factors translate into a higher fatality rate per mile driven than their middle-aged counterparts, so that the older adult starts to look like a teenager when you look at miles driven. Because older adults do drive less, the absolute fatality rate doesn't look as dramatic as this, but the per mile rate does. So one really good guide for you is the Clinician's Guide to Assessing and Counseling Older Drivers. And American Geriatric Society and NHTSA got together and said, physicians need more guidance. This is their 4th edition. And these are the tests that they recommend. If I can really flip through these pretty quickly. I wanted to do a tangent and let you know that we have a very exciting study that just finished. We were funded by AAA Foundation for Traffic Safety to recruit and follow for 5 years 3,000 older adults from around the country. So we did 5 cities. And for 5 years, we've been collecting their medical data to the point that they have to bring into our office every year a brown bag with all of their medications in them, including their supplements. And then we put a device on their car that measures their every move. And you're saying, how did you get 3,000 adults to agree to be monitored the day and night in their cars? Somehow this happened. And so we've been able to look over the last 5 years since we started the study at some preliminary stuff. Just this month, we finished testing and closing out the study on our last subject. I'm hoping that as we go forward over the next year, that the 30 or so in-house tests that we did very comprehensively, that we'll be able to say to you, this isn't the right list. We've got actually a shorter list, but that has more validity in terms of predicting which of our older adults is going to have a problem on the road.
Dr. Hill, there was a question as to whether this was the long road test, the long road study.
That is correct. Yes.
Yeah, and what you were saying about making the screening much more compact and easy to do, I think is such an important point, because we know that we can do 50 minutes of testing and 3 hours of roadside driving with an instructor, but that seems to be ill-suited for the scope of the problem.
It truly is. And I would say that there's quite a bit of bluntness to these lists of tests in terms of trying to figure out how well does this predict driving. Even though we're talking about the concerns that we have about drivers, that crashes are still, a low outcome. And so it makes it challenging. So when we talk about pre-screening the older adult, we looking at those medications, and deprescribing is so important. I mean, it's important for so many reasons, as our patients are shared with other docs who may or may not be adding medication. So as the slide said, we test for visual acuity, and at the point it reaches 20/40, you send them to ophthalmology. When it's 20/70, send them to on-the-road assessment, who then might make a decision if that patient can continue driving. But hopefully at 20/70, people are voluntarily giving up their keys. And then peripheral vision as well. Again, if people have peripheral vision deficits and they can't be corrected by ophthalmology, then an on-the-road test might be needed for those who aren't willing to stop driving. The tests for frailty are range of motion, rapid pace walk, and get up and go. The reason we do those is that frailty of itself is associated with crashes. So it's nice to find out if your patients are frail for so many other reasons, but certainly for driving. And then for the cognitive tests, there's a series of options. The maze test, where people practice and then have to do it within a given period of time and with or without errors. The Montreal cog. So if the Montreal cog gets done, it's so inclusive that not all of the other tests need to be done. Clock drawing, I love. Most of my patients, English is a second language, and clock drawing is such a nice way of doing it without having to worry about literacy, just some numeracy. And it's easy for my patients to understand. These are some of the clocks that I've collected over the years, and highly correlated clock drawing and the 3-minute, the 2-minute 3-word recall are combined to make something like 93% valid testing for dementia, even though they're screening tests.
Dr. Hill, if you go back to the clocks just for a second, if you joined us on earlier versions of GM Insights, this would meet Dr. David Loring's mom's criteria of abnormal clocks. And so you didn't talk very much, Dr. Hill, about the subtleties of scoring. You're just looking at gross abnormalities and grossly normal.
No, you want to see that it's two hands at the time set correctly, and that the numbers are put inside and in the order. The clock drawing that AGS recommends is just pass fail, but you can do a more subtle version of clock drawing. And then I also like trail making because, again, you only need minimal literacy, numeracy, where you alternate numbers and letters and set the clock. And if they can't do it in 3 minutes or less, then they fail. One thing about trail making is that it's because it's a continuum. You can see as people start to approach 180. If people refuse it, the correlation between refusing to take these tests and dementia is also high, which I think is really interesting. So here's some of the trail making examples. So just a quick word about what do you do when you get the results. If people pass all your tests, you can, again, deprescribe, try to keep them fit because frailty and brain health is so important. But what about if they fail? So California's a mandated reporting state. There are only 6 in the country. Georgia is not. That means you have the option of reporting people to your equivalent of DMV. And if they fail vision, you have the opportunity to do that. In California, if one of my patients has a lapse of consciousness, like other than something that is so predictable that we think it's so explainable that we think it's not going to happen again, but they have a recurrent problem, seizures, hypoglycemia due to diabetes or sleep apnea due to a sleep disorder that causes them to fall asleep at the wheel, that would be reportable. But the dementia is also reportable and considered a lapse of consciousness. So I guess in Georgia, this would be voluntary reporting.
Yeah, I looked this up right before we started here, just to keep folks in Georgia thinking about Georgia laws. There is something that's called the DDS 270, which is the request for driver's review. And this, oh boy, it disappears with my background. Sorry about that. But this form asks you to, you're not anonymous, but they will allow you to be a protected reporter. And it could be done by family members, physicians, citizens, and the like. And then once you fill out one of these, then the state sends a medical review process form, which you have to go to your physician or provider and get filled out within 40 days. And then you can do it. But Yeah, George, from Dr. Merck, Georgia is not anonymous, and anyone, family, friend can report. Need name and address of driver, and helpful to have date of birth. So they are asking you for some information that you might not have if you've been, nearly missed as a pedestrian on the street. But anybody can ask, but it's not mandatory, as people were suggesting. Yeah, that's where we are in Georgia.
I really like being in a mandated state. It's it's like reporting all of the other public health concerns. I mean, we report TB and STDs and on and on and on. The 60 or 60, 70 or so things. It takes the guesswork out of I don't have to say to the patient, I'm really sorry, I'm reporting you. And in a state where it's voluntary, I think that conversation is more difficult. And I can just say, in California, you had a seizure. I have to report you. They're going to ask me more questions. And if your seizures are well controlled, they won't take away your license. I do find it very helpful. So I know we're just about out of time. And I just wanted to say a quick word that these driving rehabilitation specialists that are usually OT trained, who then went on to specialize, are really helpful. Some people say, doc, you've never seen me drive. I'm a good driver. I haven't gotten a ticket. And they can take people out on the road. They have dual controlled cars. Also talking about driving retirement rather than quitting. Saying everybody retires at some point. You want to do it before you have a problem. We have some counseling videos that would help. As I said, we also have videos for medical assistants. I have trained my medical assistants to do the majority of these tests, not range of motion and not strength, because I think that's beyond their scope of practice, but they can certainly do my cognitive testing and then bring me the results. They either do it before or after the visit, and then we follow up. We have more and more alternative transportation. At least there's rideshare. People may say, well, I can't afford rideshare, but they're averaging now that the average cost is $8,000 a year to keep a car. And I would say, looking at the way car prices have gone up since the pandemic with the shortages, that's likely much higher. So that goes a long way towards rideshare. We talked a little bit about the effect of COVID on the road behaviors. Also, COVID and long COVID has issues related to cognitive impairment as well.
Dr. Hill, there was a question related to COVID in the chat from Lila Ralston. I'm just going to read this one to you.
Yeah.
Is there research on long COVID and driving? I'm aware of one study that found specific visuoconstrictive deficits in folks with long COVID, which, given the huge number of patients, is very concerning. Any specific comment about her question?
I'm glad that you were able to cite that. I don't know that study, but just from what I've looked at with the neurological consequences of long COVID, I think that this is going to become more and more of an issue, not to mention the increase in alcohol, other drugs, and depression that we're seeing. And our group has also looked at, well, I digress, but the effect of depression on driving safety, and found that it increased crashes twofold at least.
Wow. Dr. Hill, there was another question. I know that at UCSD you have a partnered VA facility, the San Diego VA. And there was a question from Anna Merck, who's the provider at the VA. She's interested if you or anyone has insights as to why the VA does not allow their employed providers to report unsafe drivers. You are in a situation where the state of California makes you mandatory reporting, but the federal government says that that's not our role as VA staff physicians, according to Dr. Merck. Dr. Merck says, I've asked legal and risk management and they have no answer other than that's how it is. I've heard that at the VA, but I was wondering if you had any insight based upon your experience at the institution and maybe even sending your preventive medicine residents around.
I don't think we have that problem at the VA because of being in California, and I've given this talk and also done some screening at the VA myself. But certainly that would be worth bringing up, and I think that the federal VA offices, if that's somebody that you work with regularly, that this could be looked at. I'm gonna stop screen shares because I think we're out of time, and then we can just
We,
finish up. But the VA seems, I think it would be worthwhile kind of taking these issues to higher pay grade.
Office of Regional Counsel, Dr. Merck might be a good place to start with that. They represent multiple states and could give you a more specific answer. Dr. Hill, I know that I asked you to summarize 20 years of really impressive research work into 30 minutes. I did have one other question from Dr. Gabriella Cohen. Do you use the clinical rating score in order to determine whether or not they can drive? Is it it's a CDR of 0.5 is a yes, and a CDR of one is a no? What are your thoughts? There's some topics about, the link of a diagnosis of dementia and maybe even the stage of dementia being the real test. Welcome your thoughts.
We don't, in California, which I think isn't a bad model. When they send you back that larger form, and it sounds like Georgia does that as well, then you have the opportunity to put in more detail about what the specific concern is that you have. And I would encourage you to be as specific as possible, what the test scores were, what you observed, what the family members are telling you. And usually, if you can rate this individual as having mild, moderate, or severe dementia, that will help your DMV then to make a determination on whether this person can drive. So just to remind you, we're physicians. So physicians and cops don't take away licenses. They only recommend to your DMV what the problem is and what the extent of the problem is. So the more specificity that you give them, the better that is for them to be able to make a decision. And generally what I'm hearing is that if you say somebody has moderate or severe dementia, then they will take the license away from that individual. But if it's mild dementia, they may take that person out on the road themselves and make a decision. So as you bring together all of your testing and sort of the totality of this individual's condition, then that would be the decision to make. But once they hit moderate, it's not safe.
Thanks so much for that comment. I pulled the Georgia instructions that are given to us, and they're rather telegraphic. I'll just read very quickly. Question A9, any evidence of cognitive impairment? A10, memory within normal limits? And A11, frequent or intermittent confusion? Those are all yes/no boxes with no additional place to put information in. So maybe some fodder for what we might do in Georgia here to get up to speed.
Exactly. And we would be happy to share our forms. I know that Missouri, David Carr has done a fabulous job. He's a geriatrician at WashU, has done a fabulous job of looking at how to improve their state forms, as well as being a great geriatrician. He's also does a lot of driving safety work.
Dr. Hill, thanks so much. I want to just give a half second for folks to come off and see if they have any questions to answer. I know that we are at time, but a real great opportunity for us to spend some time with you. Really appreciate your taking time out of your day. I know that Lori Beth has put into this slide share information for those of you who attended to just give us some information about how you liked today's program. Any quick questions that folks have?
I would also be happy to answer questions by email, just because I know everybody has to get back. If you want to email me at my UCSD email or through our TREDS website, both will reach me. And I'm happy to carry on the discussion or even talk about the larger issues related to the state or the VA.
Great. Hey, thanks so much, Dr. Hill. Hey, thanks everybody for joining us. We hope you had a really awesome 30 minutes. I know I enjoyed it tremendously. Thanks, Dr. Hill. We really appreciate you.
Thanks for having me.